Well, let's say good afternoon, and thank you very much for the opportunity to share this case presentation, which we have called Biomass Black Smoke Lung Disease, which is an increasingly prevalent but under-recognised global condition. And as you mentioned, this is work I started while in my fellowship at the University of Alberta. And I'd just also like to acknowledge the input of all the co-authors in producing this work. So I have no disclosures. So the outline of the talk. So first, we're going to look at three case presentations briefly, which is where our observations came from. And we were fortunate to have histology samples, which led to the development of this paper. Then we're going to look at what is biomass fuel, a brief history of anthracosis, an overview of the demographic characteristics, and also explore some of the pathophysiology contributing to a distinct form of chronic obstructive pulmonary disease. And then finally, we'll explore looking at biomass smoke exposure as a possible model for lung disease in wildfire smoke or more general air pollution, and then conclude with a summary. So the first patient is a female patient in her late 50s, and she had latent tuberculosis infection and presented with night sweats, weight loss, and reduced oil intake, but she didn't have any fevers. Her symptoms did not improve with short-acting beta agonist inhalers, and she had moved to Canada from Eritrea approximately 15 years prior. And you can see here an image from her CT thorax, and it showed a patchy, diffuse ground glass opacities at both sides, and they were slightly more confluent in the mid-lungs to lung bases. So she had some histology, which we'll show soon. Then patient 2, she was 50, early 50s patient, and she presented with a dry cough for 1 year, which happened following a COVID-19 infection in 2022. She had episodes of pneumonia. She also had a history of rheumatoid arthritis, which she was being treated with. The second patient, she was originally from Ethiopia, and she had worked in a long-term care centre in Canada. She also had some lung wedge biopsies. And our third patient was a lady in her early 70s. She had moved to Canada from Afghanistan the previous year. And she was being investigated for tuberculosis, and she had no respiratory symptoms, cough or dyspnea, and her weight was stable, but she did have night sweats and chronic back pain. And her imaging of CT thorax, which I haven't got to show you, but it suggested an acute infection and aspiration of the lower lobe. And she also had enlarged intrathoracic lymph nodes. So the possible diagnosis for her initially was granulomatous inflammation secondary to possible sarcoid or amyloid. And she had a bronchoscopy and a mediastinal lymph node biopsy, which I'll show. And she had no known exposure to TB. So let's explore the histology findings. So just as a way of comparison, I'll show you some normal lung histology. So this here is the pleura here, and here we can see the airways and how this is a bronchus and this is the corresponding vessel, how they're a similar size. You can see the cartilage here. And then these subdivide into smaller airways until we get to the terminal bronchioles, which are the final smallest conducting portion of the respiratory tree. Then beyond that, you have the respiratory bronchioles and the alveoli, which are for gas exchange. So here is the histology from patient 1. So I won't show patient 2 because they had similar features. And we've got here histology from the upper and middle lobe. So here we have from the right upper lobe showing a central airway fibrosis around here. We've got lymphoid aggregates, which I'll show, and some mucoid impaction. And elsewhere, there's not severe emphysema. You can see the alveolar spaces are relatively preserved. There's also some anthracotic pigments, which I'll show. This was from the middle lobe, which was less affected. So here we can see the anthracosis, which is this black pigment here in the wall. We also have bronchiolar metaplasia, where we have a ciliated lining extending out into the alveolar spaces, so this shouldn't be here. And then we also don't have much emphysema, as I mentioned. Now, this is from the upper lobe, which is more affected. So we've got mucus impaction, where the M is. We've got a dilated airspace, which is over twice the size as the corresponding vessel. We've got lots of anthracosis pigment, and we've got a thickened wall of the vessel. And here we have mucus impaction again, foamy macrophages. We've got the anthracotic pigment in the foamy macrophages as well. And we've got the fibrous tissue developing. We've also got lymphoid aggregates around here. So patient 3, as I mentioned, she had a bronchoscopy and lymph node biopsy. And her bronchoscopy, by way of comparison, the normal mucosa here is a light pink color where you can see the vessels. But here we have this black discoloration, and this is termed bronchial anthracosis. And this is due to carbon and other pigments and deposition. And I mentioned that she also had a lymph node biopsy. So here her lymph node has become fibrotic, and it's got lots of anthracosis pigment in it, which you can see is the black pigment. So I think I may have mentioned that all 3 patients, they were never smokers. They didn't have any evidence of TB, or their cultures were negative. So on further inquiry by the clinical team, patient 1, she gave an occupational history of working many hours as a cook each day using traditional Eritrean methods, cooking with in an enclosed space where there was a poor ventilation and using wood fuel. Patient 2, on further questioning, she also described during her first 20 years in Ethiopia that she regularly cooked with wood or coal, sometimes cow dung, indoors, again with poor ventilation. And the third patient, she reported that she spent approximately 2 hours per day cooking using wood and cow dung in a small kitchen. So on that note, we will now move on to the second part of the talk and look at what is biomass fuel. So essentially biofuels or biomass fuel, they broadly include plant biomass and refined products which are combusted for energy. Now, in terms of the solid fuels, we have the raw or unprocessed wood, can have crop residues, which are also burnt during agricultural methods. We have dung, like the cow dung, and like that's pictured here from a village in India. And we have processed wood pellets, which are better for storage and for transport. So the biomass fuels are most commonly used in sub-Saharan Africa and Asia, but it should be emphasized that the use varies greatly between countries and continents, and its use is greater in rural compared to urban environments. However, in urban environments, industrialized nations, there is use, for example, wood-burning stoves and biomass boilers, although there is much better generally control of the ventilation, and there are regulations as well concerning the technology and emission levels. Now, it's estimated by the World Health Organization that approximately 2.3 billion people worldwide are estimated not to have access to clean fuels technologies. And it's also estimated that this attributes to 3.2 million deaths worldwide. And women and children are at significant risk due to spending increased amounts of time indoors and exposure from household pollutants due to, for example, cooking. So this is a map from 2022, also from the World Health Organization. Now, the blue areas are the areas where over 90% of the population have access to clean fuel technologies. And you can see that in the Central America region, Sub-Saharan Africa, and South Asia, that there's poor access to clean fuel technologies. And the numbers there are percentages. Okay, so now I'm just going to as a sort of a brief aside, look at history of anthracosis. So the idea, what they called it then in the 1800s, soot, or what we would probably now call as smoke in layman's terms, from fuels that could affect the lungs, has been known about for quite a while. It was talked about by Samuel von Summering, who was a German anatomist, amongst other things. And in 1808, he posited the idea that soot from burning tallow, animal fat, reached the lungs, but he didn't have any evidence to prove this. A few years later, a chemist called George Pearson, in the lower right-hand box, he suggested that fine smoke reaching the lung from burning was due to carbon. but this idea did not gain traction. And then in the top left, Thomas Stratton was a physician in Edinburgh, and he coined the term anthracosis from studying coal miners' heavily blackened lungs. And he coined the term anthrax due to it meaning coal or carbon in Greek. So nowadays, we use anthracosis to mean carbon deposition for general ambient carbon, and we would use coal workers' pneumoconiosis for the blackened lungs in coal miners. And this review, Black Lungs in the General Population, and you look at an old dispute, is really comprehensive and well worth a read. So terminologies, bronchial anthracofibrosis would be the blackened bronchial mucosa like we saw in the patient 3. There's been terms hut lung or fly ash lung. And then biomass black smoke induced lung disease. We use this because a Swedish group, Parmental, they described patients who had exactly the same circumstances as our 3 patients, who were migrants from countries where they had used high amounts of biomass fuel and moved to countries where there was low use of it. So the pathophysiology. So on performing literature search looking at this, much of the literature is published in Central South America, the Middle East, and Asia, and awareness seemed to be low, anecdotally at least, in Western medical practice. Now, excess exposure of the biomass can increase the risk of chronic asthma, repeated acute lower respiratory tract infections and bronchiectasis, and also cause increased risk of TB and sarcoid, and many other conditions, including increased risk of lung cancer and cardiovascular disease. It can also, interestingly as well, so the third bullet point, a study by Gunbatter et al., they found that there was limited interstitial fibrosis, which we also found that as well. So another comparison I'd briefly like to make is about the distinction between smoking, which you get emphysema, which is destruction of the alveolar air spaces. So this left-hand image, we can see there's destruction of the alveoli, which we normally saw, and that leads to reduced surface area, reduced gas exchange, and also difficulty expelling the air as you're breathing out. You're losing the elastin fibers. But on the right-hand side, we can see here the lung that I showed earlier. There's still alveoli is comparatively relatively preserved. And I used at this point also make the point that these very small particles can cross the blood-brain barrier and also the placenta, and it's difficult to avoid exposure for patients who are affected with excess biomass smoke. So the knowledge about avoiding cigarette smoking is well known in pregnancy, but for biomass smoke, it's probably not as well known, and it's also maybe more difficult to avoid. So to summarize the histological findings we essentially found airway-centered changes, which were the bronchiolectasis, the dilation of the small vessel, the small bronchioles, mucoid impaction, and thickening with fibrosis around the airways. In its severe stage, it can actually lead to development of bronchiolitis obliterans. This can be seen in other conditions, such as after lung transplant and stem cell transplantation, but also is known to occur after exposure to inhaled toxins and gases. And it can also be seen in autoimmune conditions. And we saw the lymph nodes also showed heavy anthracotic pigment. Okay, so just to conclude, we wondered whether this lung injury could act as a model for fire smoke or more general air pollution. So more recently in the general media and awareness, there's been more awareness of wildfire smoke and what it can mean for health impacts. So this is from the Washington Post last month after the fires in LA. And these on the right-hand side are 2 photos I took of the wildfire smoke in Alberta in 2013. Now, obviously, the intensity of the wildfire smoke is different. It could be a higher intensity but shorter duration. But if you live away from the fire, it could potentially be a lower intensity and longer duration. And if it was repeating each year, it could cumulatively still lead to great exposure. So this Another issue is general air pollution. So this is smog in New Delhi, which has been recorded to have one of the worst air qualities globally recently. And this is from the BBC News website, comparing in 2019 on the left-hand side before the COVID pandemic and lockdowns, and on the right-hand side is in April 2020 in the global lockdowns from the pandemic, and the air quality improved, and you can see that visually. So another interesting feature about the smoke particles from fires is that they can be detected by satellite. So CAMS, or the Copernicus Atmospheric Monitoring Service, they use satellite and optical depth, aerosol optical depth measurements, and they recorded smoke reaching Western Europe from the fires in Canada in 2013. And also the Met Office independently also saw the smoke when they're doing their weather reports. So finally, air quality guidelines. So air quality guidelines are published by the World Health Organization, and the most recent ones are in 2021, and it's quite a comprehensive document. Now, annually, the recommendation is that the PM 2.5, which are the particles less than 2.5 microns, should be less than 5 micrograms per meter cubed annually. Now, for the biomass smoke and wildfire smoke includes and also fossil fuels, there isn't a particular air quality guideline for the carbon component of that, or elemental carbon, because there isn't the evidence there. However, 2.5 PM 2.5 are measured, and more than 99% of the population live in areas where the air pollution actually is above the WHO air quality guidelines. And they estimate that 4.2 million deaths of a year are attributable to ambient air pollution. So in summary, those exposed to excess biomass smoke are increased risk of chronic asthma, lower respiratory tract infections and bronchiectasis. They may present with lung disease and cough, impaired lung function, air trapping. At-risk populations are women and children who have never smoked. More generally, the GOLD guidelines for chronic obstructive COPD have recognised PCOPD for COPD caused by air pollution. We finally would postulate that perhaps chronic inhalation of wildfire smoke and increasing levels of other environmental pollutions could lead to similar patterns of lung injury, but this certainly needs more research. And the most important message we probably want to try and transmit is that specifically probing for biomass fuel use and smoke exposure should be sought, in our opinion, in at-risk populations, especially women and children who are never smokers, who have previously lived in an area where there's high use and they have impaired lung function and air trapping by CT scans and small airway disease. So I'd like to acknowledge the 3 patients for their willingness to permit us to report them in the medical literature. And there's a few references here, so I'll just go through them, and then if you want to look at them later, you may. So thank you very much. Sorry I'm a bit over time. Thank you.